Thank you. Good afternoon. I was asked to give a lecture here. We never agreed on the title, but it ended up being Total Hip Replacement, Follow-up and Loosening. How can registries be used? These are my disclosures, support from a number of companies, a little royalty, and otherwise not really any paid conflicts, and nothing relevant to this presentation. The efficacy of a medical intervention must be based on scientific evidence. We are all obliged, or should be obliged, to build the clinical treatment on evidence-based principles. And how do you generate evidence then? You can do randomized clinical trials. That's difficult in total hip. It takes a long time, and you need a lot of patience. Or you can do observational studies, registries which I spent most of my life working with. Some milestones and some innovators in registries has been Mark Coventry, who really started the Mayo database in 1969. Lars Lidgren started the first national registry encompassing all Swedish knees, and that's been running since '76, and Peter Herbert's my mentor and close friend, started the Swedish hip in '78. After that, there has been numerous registries, regional, national, started up. Two critical questions. What is the current evidence on implant fixation and reason for revision? And what is the current evidence on bearing surfaces? Swedish Registry, this is the web portal, have very few parameters that's been used for many, many years in their analysis. ID number, gender, age, diagnose, implant details based on barcode scanning, cement type, and type of incision, surgical technique. All that is in any medical record wherever you are in the world, and you don't really need physician compliance to report the data. And the mission running a registry is to improve the outcome of total hip replacement. It's a quality control system with focus on the procedure. It's not an implant registry. And the hypothesis is, of course, that when you feed back the data to the surgeon, the participating surgeons will reflect and improve if they're not as good as the rest. Internet, the IT development has facilitated feedback of information, and the Swedish Registry has been running for more than 30 years now, have today 350,000 primary hips and a little more than 31,000 revision hips. These two slides shows each clinic's result between '79 and 1991, where you can see 100% is the best outcome. The lower you get, the higher revision frequency you have. If you do that for a later time period, you can see it jumps up by approximately 3% units. I think this is an effect of running the registry in Sweden. And anybody who would start doing that will get the same effect. Basic international registry information. I'm going through Australia, Canada, New England, Wales, New Zealand, Denmark, Norway, Sweden. All outside of Canada having very good coverage, and you can see UK is now up to more than 400,000 primary hips and revision hips, and increasing annually by more than 70,000. So there's a lot of information out there, more than 1 million patients in this slide. Basic demographic, the mean age at surgery doesn't really differ wherever you look in the world. Outside of New Zealand, there is a dominance of female patients as well. Indication for doing this doesn't differ really throughout the world. Rheumatoid arthritis are decreasing. Due to specific issues, the Scandinavian countries have a higher frequency of total hip on hip fractures, and that's the reason you can see here there's a higher number of fractures done in those countries. There's no major difference in basic demographics. Quality and information could be improved if the registries could agree on using the same classification system. Type of fixation, then there's a lot of difference. Canada, 3% cemented. Sweden, 87%, all cemented. So, no agreement here. Reason for revision, you can still see aseptic loosening is the dominating reason for revision. Of course, related to bad poly, to osteolysis, but it's still aseptic loosening. Outcome, revision burden, a rough, not statistically sophisticated measure, but showing major differences between the world if you look at hip, not really at knee. You can see US hip in Medicare population, 16.9% revision burden, Sweden, 6.4%. Let's look at outcome from 4 registries. This is the Swedish. The red here are all the cemented patients done in Sweden. You can see 88.4%. This is the revision burden, the dark red, of cemented total hips, 8%. Throughout the years in the most modern era, 9.8%. This is the same information from Sweden for uncemented, 15.6% revision burden, 2000, 2009, 14.8%. This is one of the bad working implants in the Swedish registry. There was a lot of issues with poly, locking mechanism, improper acetabular design. Still, if you look today, younger than 50, the left one is cemented, the right one is uncemented. There's no difference in outcome. You can still obtain a good result, but not definitely better result using uncemented in Sweden. And type of fixation in Sweden still, if you look here, in the past few years, they are leaving cemented for uncemented and hybrid. Go to the Norwegian registry. These 2 slides just roughly compare between different time spans, uncemented to cemented. And you can see cemented on average is higher than uncemented. And the Norwegian authors, leaders of the registry, conclude there's considerable evidence from our registry that cemented implants, both in femur and acetabulum, give satisfactory 15-year results. The findings apply for both young and old patients and for all diagnostic groups. Still, in Norway, cement is disappearing for uncemented and hybrid. UK, the largest registry in the world today. This is implant survival. The top blue curve is cement. The bottom gray is large head metal and metal. Number 3, the red one, is cementless. Still, 5 years out in the UK registry, clearly improved and better results for cemented. Despite that, cement is decreasing, uncemented is increasing. Australia, finally, the green one at the bottom is cemented, disappearing out in Australia today. Still, cemented, the blue curve, now reversed here, the green curve, have the best results. The blue one, the uncemented, have initially a higher revision rate. So in all 4 countries, superior outcome of cemented total hip. In all 4 countries, significant decrease in use of all cemented hip. Not really evidence-based medicine. Alternative ways to create evidence is to combine randomized clinical trial, observational studies, and a meta-analysis. We did that, published that in 2007, and we couldn't really, in that meta-analysis, show significant benefit on neither of these fixation methods. And that's the take-home message from that study. Bearing surfaces in total hip, what should it be? Metal, ceramic, and poly, metal and metal, ceramic on ceramic, ceramic on metal. Once again, the Australian study on 151,000 primary hip have shown this. Metal, significantly higher failure revision frequency if you go and look at head size larger than 28. The best is still metal poly. Same in England. You can see here the resurfacing. There. Some of those have 12% revision rate at 5 years. And if you look at cemented stems, 2, cementless stems, 3.6, cemented cups, 1.8, cementless cups, 2.9. And all that we know are associated to a lot of still unclear failure mechanisms. But be restrictive using in smaller patients with head size below 50. Implant brand seems important. There's a major recall still running, and we don't know the long-term consequence of this. Sure, there are limitations in registry information on type of poly, type of ceramic bearing, and several more, and there are limitations. How do we as physicians determine the optimal treatment for the patient? We are kind of want to do the best for my patient, or temptation using the latest and the greatest. Clinical benefit, the most noble motivator, competition to be the latest and greatest, consumer demand, which is increasing, the web, advertising, and of course manufacturers. This is the way you do it in US. Jack Nicklaus, Jimmy Connors, May Lou Retton, and Floyd Landis, all famous athletes, each advertising for their implant. They're actually getting money for doing it as well. So what have we learned in these past 30 years with respect to primary? Not enough. We have learned that registries can facilitate outcome improvement when orthopedic community is compliant, like in Sweden, Norway, Denmark, Australia, England, Wales, and several more on the way. Can provide critical information on outcome and identify clinical problems, but not the solutions. We have also learned we need more registries, and we should be very critical and skeptical when new technology is introduced. Each country, region needs a registry with strong support from you, the orthopedic surgeons. Aseptic loosening has decreased, is still the dominating reason for revision. Follow-up of total is due to the high volume, best performed through regional national registries. New and unproven technology need careful monitoring. Thank you.
So thank you very much, Mr. Malchau. It's of course a very important topic, and maybe you have noticed that France was not mentioned because unfortunately we have no register till now in France, and I am ashamed to say that because it's certainly very, very important for the outcome of prosthesis, and we'll work on this subject. Now, have you some questions for Mr. Malchau?
If you don't have any question, let me ask you one. How many here report to a registry? Not too bad. 5 years from now, I hope everybody will put up their hand. All right, I think we should...
No question, everybody is happy with these results?
Everybody accept?
Did you think that the cemented prosthesis maybe were better than the uncemented in long-time survival? Is it something that you think of, or are you surprised by this conclusion? Nobody answered. Because
of your hip sockets do you cement?
My praxis? I don't do any patients above 50, so I use mostly uncemented. The message is really that you should be able to handle cement because the elderly population are having a much more predictable outcome if you use cement. That's really, I think, the basic conclusion of this talk. You shouldn't use cement in all patients, definitely not. But you should be able to use both principles.
Okay, so just one question and then we have to go on.